Welcome to Innovations in Blood and Tissue-Based Biomarker Profiling, New Tools in the Management of Gastroesophageal Cancer. Oops, I messed that one up. A few housekeeping notes before we begin. All attendees are muted and video is focused on our presenters and slides. Should you have a question, please type it into the Q&A at the bottom of your screen at any time. We will save time to answer your questions before the end of the webinar. I would now like to introduce your moderator for today's session, Dr. John Woog.
Good evening. Thank you, Ryan. And we'd like to start by thanking Aki Smith and Team Hope for organizing and sponsoring this very special webinar. As many members of our community know, biomarker-driven therapy really is a new frontier in terms of how we treat esophageal gastric cancer. It offers the potential for more personalized and effective and hopefully less toxic treatments. Over the next hour or so, we will explore advances in tissue-based genomic profiling, innovations in blood-based assays, including liquid biopsy and ctDNA-based tools, and then the real-world applications of these assays in terms of treatment selection, patient individual surveillance, and monitoring for recurrence. We are absolutely delighted to have with us today two experts representing Caris Life Sciences and Natera, who we all recognize, I think, as two leaders in this field. Our webinar will begin in terms of organization with presentations by each of our guest speakers for about 15 to 20 minutes or so, following which we'll have the Q&A session that Ryan alluded to. Please feel free during the presentation to type in your questions into the Q&A. The chat feature will be disabled. The one other comment I'll share, and we'll remind everybody of this again at the end of the presentation, is that 1 week from tonight on the 25th, we'll have our Ask the Expert support group with a GI oncologist who will be available to answer more direct treatment related questions. So just to know that if those questions are not addressed this evening, there is a really good opportunity next week. Well, to kick us off, it's really my pleasure to start off by introducing Dr. Ari VanderWalde. Dr. VanderWalde is a medical oncologist, bioethicist, and an active cancer research scientist with particular interests in cancer immunotherapy. Ari is currently vice chair of the Caris Life Sciences Precision Oncology Alliance and head of global clinical trials at Caris. We are delighted again to have Ari join us to discuss biomarker assays offered by Caris that may be relevant for those of us with esophageal gastric cancer. Ari?
Hi, everybody. Hold on. I'm just trying to share my screen. Give me just a second. So the title of this talk is The Caris Life Sciences, a Complete Solution for Molecular Profiling, which is a fancy way of saying use us instead of anybody else. But I'm not going to do that because I think the most important thing is that you appropriately treat cancer and that you make sure that you take all the diagnostic tests that you necessarily need to do to be able to do that. I think that this audience is more sophisticated than most, but it's going to be a little bit like a video game where each level is a little bit more complicated than the one before it. And so if it seems kind of easy to you in the beginning, that's great. You can just see whether or not I say something in a way that's different than you've heard before. Otherwise, it's going to get a little bit more complicated as we go along. So as you probably know, precision medicine is basically taking information that is specific to an individual patient and finding ways to precisely treat that information, that type of disease in a personalized way and in a precise way that ultimately targets something that is specific to that cancer in that person. We've used the term over the last 10 years or so specifically to look at mutations in individual cancers. Cancer sometimes has mutations that develop or various different alterations that develop that ultimately lead it to escape the normal confines of the body's control mechanisms for making sure that cells don't run amok. And many of these mutations that develop can potentially be targetable by various different drugs. And so the main way in which we're able to do this is by looking at mutations, but there are many other ways in which we can look and qualify patient tumors in ways that they could potentially be targeted by various different individual agents that would allow them to be precise. And I'll talk about some of those as well. So in the old way, the way that we initially did precision medicine is we realized that each patient's cancer was different because they looked different under a microscope, or they started somewhere different in a patient's body. So lung cancer was treated differently than breast cancer, is treated differently than stomach cancer, is treated differently than upper esophageal cancer. So that was the first. Then we started looking at it under the microscope, and we realized that, and this is a lung cancer example, that some patients have adenocarcinoma, which means that they have a specific type of histology. Others have squamous cell carcinoma. Others have small round blue cell tumors that ultimately lead to a totally different disease path. And then we realized that actually there are mutations that are actually available as well that we can see present. And again, this is a lung cancer example. That we can see present in cancers that are beyond just what we would otherwise expect to see under the microscope. So about 12% of patients with lung cancer have a mutation in EGFR. About 3% have a fusion or an alteration in ALK. There are a number that have alterations in KRAS. And what's interesting about all of these is that we found small molecules or antibodies that can particularly target these mutations and allow us to kill those cancers without killing with the healthy tissue around it, which was the way that chemotherapy used to work. And so this is basically the invention of targeted therapy, and it's because of our capabilities in identifying molecular targets through the precision oncology approach. The problem and the need for precision medicine is not just that chemotherapy is too toxic, it's also that most drugs fail most patients most of the time. That's a direct quote from our Chief Medical Officer, George Sledge. He says it very well, and I've practiced saying it, so it rolls off my tongue. But what it basically means is that drugs don't work. And the trick is really to make sure that the drugs that we have available for cancer work more often. And generally speaking, this is not just an issue of patient care, it's an issue of public health as well, where we are treating patients unnecessarily with high toxicity and very high cost in a way that there is no good being gained either by those patients or by society in general. On the other hand, when there are biomarkers approached, the response rates are much higher, which is, of course, really important for the individual patients and ultimately saves society money as well. Because you get longer treatment with those drugs because they work for longer. And you're not throwing useless medications at people that are very high in cost. We talked about different types of markers that can be seen in general in patients. Those include both mutations, fusions, IHC expression, RNA expression, various different types of ways of doing it. But ultimately, when we think about biomarkers, we're really thinking about it in terms of what does it actually mean for the patient. So a prognostic biomarker is this marker going to likely predict that this patient has cancer or will get cancer, and how they're going to do with that cancer. And there are a number of biomarkers that exist in that way. They're the diagnostic biomarkers, which basically help us determine what type of cancer it is, which mutations are present, and can we actually determine based on that whether or not we can further subclassify that mutation. There are predictive biomarkers, which is largely what we've been talking about, meaning does this biomarker, does this mutation, does this fusion tell us if a drug is going to work? There are pharmacodynamics, which basically can help us using mutations that are available determine whether or not what dose of drug is necessary, what dose of drug might be too toxic. And then finally, there's a recurrence biomarker. Can we tell based on looking at the patient's molecular features whether or not the cancer is going to come back? So with all of that background, this is a little bit about Caris and how it works. So the basic way that Caris works is that it takes a piece of tissue that has been usually taken from another biopsy that has been done for diagnostic reasons for the pathologist, but sometimes done specifically for Caris testing. And that tissue is basically put in a box, sent by FedEx to the Caris laboratories in Phoenix. Phoenix does the biomarker testing, which means it runs the tissue through a really powerful DNA sequencer that also sequences RNA called the NovaSeq 6000, and it's able to identify all of the DNA, RNA, and proteins. The really hard part comes from analyzing the informatics. There are 23,000 genes that are expressed in the human genome, and we test all of them. And so we need to figure out what's important, what's not important, and how to actually determine whether or not each thing that's found actually meets a threshold for being positive or negative, et cetera. Once that's done, the tumor profile is generated. It comes into a report, and that report is looked at by physicians and helps them, together with the patient, determine what therapy is best for that patient. One of the things that we do, just as an example of ways in which we really try extra hard to ensure that we're getting the best test results that we can, is we actually take the tumor that's taken out of the patient and we make sure that we get it out away from all the healthy tissue around it. And that's important because if you have a lot of noise, it can be really hard to see a signal. Healthy tissue doesn't have the mutations that the cancer cells do. And so we literally go in with a micro dissector and we take out on the individual slides the stuff that by a microscope shows us tumor. And that helps us in a very sort of gross way to ensure that the tests are going to continue to be as accurate as possible. This is what our general offerings are in terms of comprehensive molecular profiling. First, there are lots of different ways in which we are able to guide therapy based on our results. We know about tyrosine kinase inhibitors and antibodies, which are a fancy way of saying targeted therapy. Targeted therapy generally is looking at these individual mutations, and they're small pills usually that end up being used in some cancers to be able to treat the cancer. And that's what I refer to here as targeted therapy. There are some chemotherapies or hormonal therapies that work well based on molecular findings that can be seen. There are some things that can be found that right now are not eligible for treatment in the standard of care mechanism, but are available to be able to help patients get into clinical trials. And then, believe it or not, molecular markers help us determine what type of immunotherapy we can give to patients as well. The immunotherapy revolution started in about 2010. It is very hard to find a malignancy right now that doesn't have at least some type of immunotherapy that is either being used in the clinic or being highly far along in testing. Some that you may have heard of include the PD-1 inhibitors, nivolumab, pembrolizumab, et cetera, and our tests help determine whether or not that is likely or unlikely to work in patients. So we do testing both via DNA, and as I mentioned, that's the full gene coverage of the entire exome. The exome is all of the genes that are expressed in the tumor, in the genome. And we have great depth of that, and that could be a topic for another talk as to what depth of coverage actually means. But we're able to see all types of different things in this. We're able to look at the chromosomes via karyotyping. We're able to look at viruses that might actually be expressed in the tumors. For example, human papillomavirus, which is more relevant in head and neck cancers than esophageal cancers, but sometimes can be found, especially in upper esophageal cancers. We can develop some signatures, including loss of heterozygosity, TMB and MSI. So those are things that can potentially be relevant as well, which have to do with total mutational burden that can predispose for efficacy of immunotherapy as well as MSI high. And then also HLA genotype, which there are some new therapies that are available that need a patient's genotype in their HLA antibodies to look a certain way, and we can determine whether that's present as well. Looking at RNA, which is the next step down from DNA in the sort of golden way in which things are done in the body. It goes from DNA to RNA to protein. Also looks at the entire transcriptome of all 23,000 genes. We're able to detect gene fusions, which can be a little bit more effective in being able to determine whether or not a certain drug that targets fusions is likely to work. And then importantly for gastroesophageal cancer, we do a number of immunohistochemistry tests as well, many of which are relevant. And this is something that requires extra tissue. It's not extra tissue from an individual test, but we have to peel some extra tissue off of the block that gets sent to us so that we know how to so that we know, so that we are able to do these extra tests looking at these slides. And I'll talk a little bit more about the IHCs, the immunohistochemistries that can be done and are done for GE cancers as well. This is what the report tends to look like. Our first couple of lines on the report talk about the drug alteration relationship, which is a fancy way of saying this is the mutation or finding that we see. These are the drugs that are likely to work, and these are the drugs that are less likely to work in those patients. These are determined based on level of evidence. If it's an FDA-approved test, a FDA-approved marker, it gets level 1. If it is an FDA-approved marker that we don't have that marker that we are officially called as a companion diagnostic for, but it's still an FDA-approved drug for that indication, that's level 2. And then if we have pretty good levels of evidence, but at the same time, it's not yet FDA approved, it can usually be looked at as level 3. Now, these are only the ones that actually have obvious known clinical ramifications of benefit and lack of benefit for them as well. But in the end, we also talk about all of the cancer type relevant biomarkers and whether they're positive or negative. This is a case of breast cancer. This report is in breast cancer. And you can see here, while it talks about the ER and PR status, which is the hormone receptor status, and it talks about HER2, which is very common in both gastric cancer as well as in breast cancer. All the ones that are negative need to be, meaning that they don't have the alteration, and therefore they shouldn't be decided on, are usually in the cancer type relevant biomarkers as well. There are also important notes that help give some context about it. And then this is only the front page. So there are many, many more pages that give innumerably more data pieces that allow us to be able to communicate with physicians beyond just the sort of basic yes, no that we might otherwise expect. Oops. Okay, sorry about that. So these are the tumor type specific immunohistochemistries that we do. And for gastric and GE junction cancers, we do on every single patient that comes in with that diagnosis, we do Clawden 18, FGFR2b, HER2/neu, MMR, which is basically the markers that help us determine whether or not something is likely to be MSI high, as well as PDL1 using the 22C3 assay. These are all affiliated with medications that can be used targeting these mutations or targeting the pathways in which these show themselves. So if you're concerned about whether or not the Clawden 18 is positive or if FGFR2b is positive, that's done routinely in all of our tests. And we try really hard to be able to adopt these tests for our patients before the FDA approval actually comes through, so that we already have some experience doing these tests. We're watching very closely where the phase 3 trials are and where the pre-approval trials are, so that we have a pretty good sense that this is what's coming through. Let's start doing it now. All of these are now for approved drugs, and we're currently, we have been doing them for some time. I'm going to skip this slide just because I think that you all know that there are many different alterations that can be seen in gastroesophageal adenocarcinomas, and I'll kind of leave it there. This is the way that we report Clawden 18 and FGFR2b. So as many of you may know, Clawden 18 positive tumor can benefit from zolbetuximab, and that is something that is relatively recent. We also have PDL1 that can be that if it is positive, it also can benefit from tislelizumab and chemotherapy combinations. FGFR2b is likely to benefit from bemarituzumab, and ERBB2, if it is positive, could potentially benefit from trastuzumab. In this mock-up case, it is not. On the right, you can see what positivity actually means. Clawden 18 positivity is if the intensity is 2+ and 75% or more of cells are stained. FGFR2b is if it's 2+ and more than 10% of cells are stained. And then the MMR proteins generally are basically whether or not there's intact nuclear expression or not. So I'm going to get back to some of this a little bit later, but one thing that I want to make sure that everybody is aware of is that if we are doing the test, and while we've been doing the test for 6 months or a year, and then a new FDA indication comes out, we actually look back at every single patient that we have at the time we've run that test. And even though that tumor at the time was not targetable, we will go back up to a year and see every single patient that had a positive marker for that and contact the physician and say, hey, this drug wasn't available a year ago, but we happen to know that they have this mutation that you didn't know was targetable, but now it is targetable. And so this is something that we think is really important. It's one of the reasons that we do these tests, try to get these tests started early on so that you don't have to redo these tests for patients who are currently struggling with the disease. And we've done this with a number of different markers. We went back, for example, one of the more recent ones that we've done is HER2 high tumors have just recently been approved in a pan-tumor fashion. And so trastuzumab is potentially likely to be able to be effective. Trastuzumab deruxtecan, is likely to be effective in many. And so we're going back to be able to see whether or not we can find patients who could have potentially benefited in our set that otherwise wouldn't have had access to the drug before the FDA approval. We also have a mechanism by which we're able to help identify cancers that people don't really know what they are. Sometimes pathologists have a hard time being able to determine where the cancer actually comes from. We have a mechanism called GPSAI that ultimately is able to, with 95% accuracy, figure out what the actual tumor type is. And that helps physicians because then they know the right way to treat the cancer. I don't know why this is coming up like this. We also have a big research conglomerate with 97 different members of both academic and community oncology settings that we do a lot of partnership with research in. We last year published over 68 manuscripts, look not just in GE cancers, but across all cancer types. And this has been a really important enterprise for us because it makes sure that we stay on the cusp of what our data can actually help show. And our database is huge. We have sequenced almost 850,000 patients' cancers in the last 15 or so years. We have a data set of about 484,000 cancers that are matched with clinical data in a de-identified fashion. So we can actually look from a research perspective into our patients' tests and be able to determine, are there patterns that we see here that can help potentially bring research forward? Including almost 23,000 gastric and esophageal cancers. We've done a number of different projects looking at gastric cancers, looking at esophageal cancers, presenting at the ASCO GI meeting, the ASCO meetings, and all of the various different conferences, as well as publishing in major journals. In my last couple of seconds, I want to talk a little bit about our liquid biopsy. So everything I've been talking about so far is based on our tissue biopsy, but we also have a liquid biopsy that was launched about a year ago. The purpose of a liquid biopsy is to be able to see, without having to stick a needle into a tumor, basically just by doing a blood test, being able to see if we can find circulating tumor DNA that is floating through the blood that could allow us to determine whether or not that cancer is targetable as well with various different molecularly guided therapies. The problem with it is there's a lot of stuff in the blood. There's white blood cells, there's non-tumor DNA floating around, there's red blood cells. And so it can get really complicated when you're doing these types of tests. And what we need to do when we do this is really try to isolate out the tumors that are actually the blood that is actually tumor-derived DNA versus the stuff that's in the white blood cells versus the stuff that is potentially just genomic markers in healthy tissue that looks like it's related to cancer. And so what we do is we actually separate out using a somewhat technically complicated system. We are able to separate out the circulating tumor DNA. We're able to take it away from what otherwise is known as clonal hematopoiesis, which are mutations that occur in white blood cells that have nothing to do with the tumor, and able to get separated out from germline findings, which are stuff that's floating around in the blood of every person, because that's something that generally is a mutation in every patient's cell. But we'll report that out as well as two. I'm going to skip through these because I'm running out of time because apparently I talk way too much. But as I mentioned, clonal hematopoiesis can occur when we accidentally see a mutation that we think is in the tumor, but actually is in the white blood cells and has nothing to do with driving the tumor. And so we sequence both. We sequence both what's in the white blood cells and we sequence what's in the blood, and we subtract out what's in the white blood cells so we can take out stuff that otherwise would potentially be causing a missed diagnosis and as a result, guiding therapy incorrectly. And this is the case where we would see BRCA2, for example, incorrectly diagnosed, which could potentially be treated in this patient, who has breast cancer, with a PARP inhibitor, which they shouldn't be treated with because this is not a tumor DNA, this is CHIP DNA. We also report up to 67 germline genes. So we subtract these out again because they're not necessarily the cause of the tumor, but we do germline testing in the blood for every single patient for up to these 67 genes. Most of these genes are very uncommon, but these represent the majority of genes that ultimately can cause predisposition to cancer in patients. The reporting of this is incidental. This does not substitute for a official germline test through a genetic counselor. But if they're found, it can be very helpful in guiding therapy as well as referral to a genetic counselor if that becomes appropriate. I'm going to skip this. And then just so that you're aware, this is out there. So we've done, as I mentioned, over 850,000 of these tests. It's covered by insurance. The tissue test is FDA approved. And we are covered by Medicare, and I believe at the last measure that I could see, over 90% of normal insurances. It represents of common insurances. We represent over 255 million covered lives in the United States, and this is something that your physician probably knows about. It is something that is available. It is something that is a common therapy, common diagnostics that are done for cancer right now. And I hope if you have used it in the past that it has helped your cancers. If you have never used in the past, that you didn't have to, and that nobody should ever have to use it again. And with that, I'll turn it back over to John.
Thank you very much for that superb review, Ari. I'd like to take a moment to again remind folks who are watching that you should feel free to enter your questions into the Q&A box on your screen. We'd be delighted to cover those. Well, it's now my distinct pleasure to introduce Whitney Herder of Natera. Whitney trained initially as a mechanical engineer and subsequently pursued training in the prestigious physician assistant program at Duke University. Whitney has extensive clinical and research experience in GI oncology, including spearheading, if I recall correctly, Whitney, a very innovative urgent care service line at the University of Colorado for individuals on active chemo who are experiencing side effects. Whitney is currently now serving as the medical science liaison for Natera, and we are delighted to welcome you, Whitney, to discuss the very important platforms that Natera has to offer us as individuals with esophageal gastric cancer. Whitney?
Thank you so much, John. I'm going to share. Can you all see that clearly?
Yes, looks good.
Okay. Okay. So I'm going to spend most of the time today talking about Signatera. Just briefly, Natera as an organization is a leader in the cell-free DNA space. So in 2013, we launched the Panorama test, which is a non-invasive prenatal test where we can identify baby's DNA in mom's blood and then help parents understand what risk their fetus is of developing a genetic disorder. And so that's really the backbone of now the oncology business unit, which was started in 2019, and that's when the Signatera test launched. So Natera has been around for a long time, a well-established lab. At this slide changes in real time. So I'm going to quote different numbers, but there are about 50% of US oncologists right now that have adopted the use of Signatera. We have hundreds of thousands of tests have been ordered. From a research perspective, we have over 120 peer-reviewed publications on Signatera. Some of these are, collaborations, and some of these are done without our knowledge, and we find out about them at congresses, which is really exciting. And we studied many patients on Signatera. We have really broad Medicare coverage as an MRD test, and you can see here gastric and esophageal cancers are missing, but we're hoping for that in the near future. And so just at a basic level, I think Ari already went over this. All of our cells die off at some point in time and release DNA into the bloodstream, along with many other things. And so what we're identifying is the tumor DNA at a very molecular level. And tumor DNA is a real-time biomarker, right? So it's really a snapshot of what's happening in the body at that exact moment in time. The half-life is less than an hour. So the Signatera test is really built on this kind of molecular residual disease model. And how we build this test is similar to Caris. We take the tumor tissue and we do whole exome sequencing on the tumor tissue. Instead of looking at variants that are clinically actionable, we are actually looking at what are called clonal somatic variants. So in this graph, it's identified as these blue strands of DNA that are present at tumorigenesis as the tumor starts, and then as it evolves over time, those same variants are present as we go on. So we do the exome sequencing, which gets us about 20,000 genes, and then we look for the top 16 of these blue type of variants. And then we create a multiplex PCR fingerprint assay. So essentially, we find those 16 variants, we make a fingerprint of those variants. And then over time, we collect your blood and we look to see if any of those 16 variants are present in the blood over time. So here you can see this blue strand is present. If we identify 2 or more out of the 16 variants, that's considered a Signatera positive. That means there's molecular disease present in the body, and you're at high risk of having a clinical relapse, or that there is tumor that's going to grow over time. So you can see here in this map, this patient started out as a positive. So this closed circle is a positive. They started some form of treatment. Their Signatera went down and cleared after treatment and remained clear as they were watched over time. So really at each of these time points, we collected the blood. Down here, when it was called a negative, we saw either one variant or no variants present in the blood. And this is what the report looks like when your oncologist gets it. We have patient portal too, so it's similar to if you get your own report. This top line shows us the most recent test and the results. So right here is the most recent test. It was negative. Again, an open circle means negative. So that's represented up here. So we get the binary positive, negative. And then we also have quantitative value that's represented by mean tumor molecule per ml. So it's an algorithm of how much DNA we're seeing present in the body at the time. So if we're calling it a negative, then that number is also negative. But you can see this patient, again, started out positive. We don't know their treatment course, but presumably got some kind of treatment. Their Signatera went down and eventually cleared. These are survival curves. So in oncology research, you will see survival curves all over the place. Another term for these is Kaplan-Meier curves. And just to orient you, somewhere on the y-axis is some form of survival. So most of these here are some form of relapse or disease-free interval. So it's usually a period of time from when there's no disease in the body to when there's a recurrence. And we're measuring that time. And then sometimes this is also overall survival. So did patients survive or not? And then on the x-axis here is some form of time. So this is time since surgery measured in months. These are days, these are months. And really what it allows us to do is see either did an intervention help someone's relapse survival or help someone's overall survival. And the way we look at this with Signatera, so this is across all different tumor types, you can see. These curves look the same, right? And I call these beautiful curves. We don't see a separation of lines like this very often in oncology research. And what that means is that this test is highly prognostic, right? So if a patient with colon cancer is negative, they're going to do extremely well. Like these patients, most of them were surviving even at 24 months out. Versus if a patient is positive, then they will not do as well at that 24-month mark. And this figure just shows how consistent this test is across different histologies. You can see here, this is stomach cancer. So what does this mean clinically, right? This shows, this is applicable across different tumor types, but this shows over the continuum of care how this test can be applied. And I'll show you some of this data as it relates to esophageal cancer or GEJ cancer and gastric cancer, and then also colon cancer so that you can contextualize what this means in a data perspective. But this is the neoadjuvant time point. So this is, before surgery. Is a patient responding to the neoadjuvant treatment? So we know generally in our data that if someone starts out positive and they clear their ctDNA on neoadjuvant treatment, they're going to do much better. Oftentimes early clearance means that they're going to do even better. There are patients that don't clear their ctDNA, and that begs the question, do we escalate their treatment at that point in time? Are these people maybe not great surgical candidates? Have we identified kind of higher risk disease? And these questions are things that we're trying to answer in research at present. They're not answered currently. And then, after surgery, which patients are going to actually benefit from adjuvant chemotherapy? Can Signatera help us identify relapse sooner? So this is in surveillance, and this is relapse and subsequent treatment. And is a patient responding to the treatment or not? Just briefly, colon cancer is, we're the furthest along in terms of molecular residual disease in colon cancer. So I just like to highlight this. We've got about 5 independent cohorts and over 6,000 patients studied in colon cancer. And these are all the independent cohorts. These survival curves match what I already described before, but you can see the consistency across these cohorts. This is in France and Greece. This is in Japan. This is in the US. So really across the world, we have really consistent data. And this is where, Ari brought up like the implications on public health, on health economics, on, trying to preserve patient or prevent toxicity from overtreating patients. And so we know in colon cancer, we overtreat in the adjuvant setting, right? We give way too many patients adjuvant chemotherapy than we should. We just don't have a great way of identifying who those patients are. And so this kind of demonstrates the power of Signatera in that setting. So patients in all of these cohorts were positive after they had their surgery. Their Signatera was positive, so there was some molecular disease present in the body. And in these 2 cohorts, it was up to the discretion of the oncologist what chemotherapy they got, if they got it or not. So the blue line represents patients, or the top line represents patients with who got adjuvant chemo, and then this bottom line is patients who did not. Same here. And you can see there's a separation here. So the patients who were positive and got adjuvant chemo benefited from it. This is adding another agent, a COX-2 inhibitor, to adjuvant chemo, and the positive patients did benefit from it. Versus this is patients who were negative. After surgery, their Signatera was negative. The top line is patients who did not get adjuvant chemo, and the bottom line is patients who did. And when when survival curves are on top of each other, that means there's no difference between the two groups. So to put this all in clinical context, there were only 20% of these patients that were ctDNA positive after surgery, of the patients we normally treat, so high risk stage 2 and stage 3. Only 20% were positive, and 80% were negative, right? But right now in our current paradigm, all of those patients get chemotherapy. So if this holds out in a phase 3 setting, then we could potentially be sparing 80% of patients toxicity from chemo, toxicity to the healthcare system. And I think that's the real power of this test. I have a few more minutes. I'm going to hurry along. So I'm back to gastric cancer and esophageal cancer. So this was a study called the PLAGAST study, and it was an observational study of locally advanced resectable gastric cancer and GEJ adenocarcinoma. There were 62 patients involved in this trial, and what they did in a prospective manner is collect Signatera before treatment started, in the middle of neoadjuvant treatment, and they were allowed to have various neoadjuvant regimens, and then after neoadjuvant, they had surgery and then had a post-surgery time point as well, and then we plotted their outcomes, which I'll get to in a minute, but just to point out, 89% of these patients had neoadjuvant treatment. You can see here, most of them had chemo alone, 85%. Some had chemo plus immune checkpoint, so 13%. And then 47% of patients had a radiologic recurrence at a median follow-up of 29 months, so just over 2 years. So these curves are showing overall survival. So patients, did they live or did they not live? And this is that time point here. So the second time point they collected, if patients were negative at that time point, they did better. The positive patients were almost 5 times more likely to die at that time point than the negative patients. And then after they finished all of their neoadjuvant treatment, that risk of recurrence goes up from about 5 to about 7.3 if patients were positive at that time point. So if they never cleared their ctDNA. And then this is that after surgery time point. We know from our other data that this time point is highly prognostic. So you can see here, if patients still are positive after surgery, then they're at about a 15 times more likelihood of succumbing to their disease than if they are negative. And then this is just another way of showing dynamics. So this is recurrence-free survival and overall survival. And essentially, if patients had a ctDNA clearance very early, they did better than if they didn't clear at all, or if they kind of cleared later on. And same with overall survival. I'm going to skip this case study. So what does this mean for you, and where are we right now? Clearly, I brought up a lot of questions in talking about that data. There's a lot of questions. Every data set that we have brings up more and more questions. And that's really exciting. We're in a really exciting space. And so as a patient, what does that mean? We know this test works great in gastric and esophageal cancer. So it's been clinically validated. We have real world cohorts, and we know how the test works. And in fact, it kind of follows what we've seen in other histologies, which is reassuring. It's a tool that's highly prognostic. What does that mean? If you're negative, you're going to do really well. If you're positive, you're at a high risk of having a recurrence and not doing as well. At this point in time, that's a little bit scary because we need better therapies. We need better treatment paradigms to try and target those very high risk patients. And we're trying to develop those. But at this point in time, it's scary if you're positive to know that you're at higher risk. The other side of that is maybe it can help you make more informed decisions about your care. It's a really objective marker, and I've seen in my experience, that it's been empowering to patients to have this clear biomarker about what's going on. We know that dynamics can help us kind of further prognosticate. And what I would suggest is this is just a shared decision with your oncologist, right? We have data. The data is, evolving quickly over time. But it's a marker that could be helpful now. And that's a conversation between you and your oncologist, and your beliefs and your method of living in the world matter as well as part of that discussion. And then finally, we have more trials coming that are going to define clinical utility. And this is just one I'm going to highlight really quickly because I think this is hopefully coming in other histologies. We have it right now in colon cancer and muscle invasive bladder cancer, but this is an escalation-de-escalation trial. Like this is a phase 2-3 trial that's going to answer the question that I brought up. If someone's negative, can we just watch them, right? Instead of giving them chemo that may not even be benefiting them. If they then turn positive when we're watching them, can we treat on molecular recurrence? If they don't have any signs of radiographic disease, can we just give them chemo at that point, and will that help their outcomes? So this study is going to answer that. And also the positive patients, if we give them escalated treatment, are we going to impact their outcomes versus just standard of care treatment? So this is a study design that is through the NRG, and it's something that I think a lot of different investigators are really interested in understanding in various histologies. So this is in muscle invasive bladder, and I will pause there.
Whitney, thank you so much for that excellent review. And I have to say, certainly, again, as a member of the esophageal gastric cancer community, it really provides hope, I think, to all of us to hear about the advances that you and your colleagues at each of your respective organizations are making. It's certainly very intriguing to hear about the prospect for possible de-escalation of adjuvant chemotherapy, given how challenging regimens such as FLOT or FOLFOX can be. Well, we do have a number of questions that have come in, more, I think, than we can get to in our remaining time. But one question which was asked by a couple of folks pertains to repeat testing or profiling. And although this wasn't asked or added specifically to the question, if an individual has a recurrence or a new site of metastatic disease, would you, and we'll ask this to both of you, if you wouldn't mind responding, would you recommend repeat biopsy of the metastasis? And in general, and we won't certainly limit this to EG cancers, but in those situations, how often do you see that the genomic or molecular profiles that you obtain have actually changed from those that you obtain with the primary test that you perform? Ari, maybe if you want to start with your response.
I'll get started. So yeah, this is an excellent question. The answer is a qualified yes. You absolutely can see changes that ultimately can potentially guide treatment. The qualification is that it's really different depending on the tumor type and depending on the therapy that was ultimately received. So the types of mutations that often occur are one of two types. They're either a tumor evolution that causes the emergence of a new drug, of a new marker that ultimately can now be receptive to therapy when it wasn't before, and that does happen. The second is what we call a resistance mutation. So because of the therapy that was being given against one type of mutation, that tumor evolved some type of ability to no longer respond to the therapy that they're giving. And that is more common. And we see that pretty routinely in, routinely is a relative word, but we see that in lung cancer very often. We see it in breast cancer somewhat less often, but it happens. And we can see it in any type of malignancy. And so if for tissue testing and blood testing, not for MRD, but for blood testing in the metastatic disease setting, As a clinician, I would say that you have to be a little bit careful about sticking needles in things when you don't think there's a high likelihood that it's actually going to change anything. And so that's why it matters what type of malignancy it is and what type of therapy they're getting. From a circulating tumor DNA perspective or a blood test, the sort of the hesitance to pull the trigger is a little bit less. So generally, if it looks like the disease is progressing or it looks like there's a really good response, it might be worthwhile to try to get a blood-based test to see whether or not it's progressing because the cancer is resistant to the therapy that it is on. There was just a study that was presented at ASCO, which is the big annual oncology meeting, that showed that breast cancer that develops an ESR1 mutation absolutely is, going to be more or less likely to be able to respond to, this or that other drug. And that happens very commonly as a result of therapies that are usually given for hormone receptor positive breast cancer. So that can be seen very commonly in certain types of malignancies, as I mentioned. And that is probably best done through a blood test. That said, I mean, if your doctor thinks that there is a high likelihood that we're seeing either a resistance mutation or potential emergence of a new mutation, even tissue sometimes might be worth rebiopsying. What I would not do is routinely, for this purpose, I would not routinely, do a biopsy every 3 months or do a blood test every 3 months across the boards just to see how the cancer is responding at this point. And it isn't, there are some tests that actually do that for immune therapy. But what they're really used for is to be able to determine whether or not a cancer is likely to respond before the radiologic study is actually done. And that's a little bit of a different question. If you want to see whether or not new mutations have emerged, the best time to do it is at the time of either progression or obvious response.
Thank you. And Whitney, might we ask, is there experience with Signatera in terms of changes in that fingerprint that you referred to earlier when you are evaluating or biopsying a recurrence or a new site of metastatic disease?
Yeah. So because we were looking at those different variants that are really trackable over time, we don't have the same variants present that are found in the Caris test, right? That are subject to kind of treatment pressure and can evolve over time. We have publicly released a study in breast cancer patients where we took a primary and then took a metastatic disease and built the Signatera test on both of those. And there was very little variation in the markers that we found in each of those tests, so little that it didn't affect the performance of the test. And so, we've done it internally in other histologies as well. And so really it's about the variant selection for Signatera. And we think we're okay doing it on a primary tissue or metastatic site, and really like the amount of tissue, getting enough tissue to build the test is what's important for Signatera.
Thank you. Thank you. That's very helpful, Whitney. And actually, another question that came in reference to Signatera. I'll read this. I've received about 5 Signatera ctDNA tests. I have stage 4 stomach cancer with peritoneal metastases. My oncologist likes to have the ctDNA data, but he doesn't let it guide his treatment plan. When do you think these tests will be mature enough to get oncologists to use it to guide treatment options? And in fact, this is a theme that we've heard a couple of times. And Whitney, we appreciate your thoughts, and perhaps you as well, Ari, in terms of how these tests fit into the NCCN guidelines, which seem to guide an increasing percentage of treatment decisions that are made by our oncology consultants, perhaps even more so in the community setting. Whitney, I don't know if you have any thoughts about when the Signatera data will be such that it will really drive decision-making in the majority of cases.
Yeah, hopefully in the next couple of years. But really that kind of phase 2-3 study that I showed with the NRG, and then we have an alliance study in muscle invasive bladder cancer. These sort of treat on molecular recurrence trials, the one that Ari mentioned is a good example, but it's with emerging mutations. But as those trials read out, I think more and more providers will feel comfortable more widely adopting the test. They really want to see that it's going to impact their patient survival if we act on it in a certain way. And so hopefully we will get some of that data coming. And I think the NCCN hopefully will kind of follow along. They like to see that level 1 data as well. That's my answer for now.
Thank you, Whitney. Ari, do you have any thoughts about tissue
Yeah.
profiling and NCCN guidelines?
Yeah, so tissue profiling is in NCCN guidelines. For most malignancies right now, it's considered standard of care, especially at the first diagnosis of metastatic disease, but in other disease types as well, sometimes in the early setting, if there's targeted therapy that can be used in that setting. Generally, the NCCN also recommends, somewhat hesitantly, doing blood-based testing. Generally, in this situation where tissue is not feasible or difficult to get or has been gotten before, it has yet, to my knowledge, really come out strongly in favor of serial blood testing in the non-tissue, replacement setting. But again, that NCCN changes its guidelines pretty frequently, and so that could potentially change things as well. Generally speaking, I think that in metastatic disease, from my perspective, the main role of doing these tests should be to see whether or not something has changed. And if something has changed, sometimes that thing that's changed could potentially be actionable and sometimes not. That is to the person who asked the question, if a test is being gotten 5 times in metastatic disease, and if the doctor's not doing anything about that, it's probably because nothing has changed. If something had changed, then there would probably be something necessary to do.
Thank you. And Whitney had alluded to the importance of trials in generating the data. And from the patient's perspective, we're in a challenging, but really, in a sense, wonderful position of having an increasing number of trials that may be relevant to our types of cancer. Ari, we understand that Caris offers a clinical trial connector. In addition to the information given on your reports, you have a separate mechanism, we understand, which can help connect individuals with certain profiles to trials that may be relevant. I don't know if you'd like to spend, we have about 2 minutes left, perhaps a minute on that, and then we have a final question for Whitney.
I'll be very quick. So on our report, we have a clinical trials connector. It's actually buried on probably page 6 or 7. It's not buried, but it's on page 6 or 7. The way that we determine what trials are available for patients is that we use a search engine necessary that we've kind of built internally to be able to match the patient's alterations in their tumor with keywords in the clinicaltrials.gov website, which is a list of, which is a government, self-imposed website where everybody puts on all the clinical trials that are available. It's not 100% accurate. Not all the trials are kept completely updated on clinicaltrials.gov, but generally speaking, we keep that search pretty done regularly and look to see which trials are open. So that's the first step. There are some trials that we do that we actually reach out directly to patients if we know of the trial. There's a program that Caris has, which is called a Right in Time program, where we contract with it's a changing number of different companies who have clinical trials that it's hard to find patients for. And so if we see somebody who has an alteration in an eligibility criterion for that trial, we actually will potentially call up the physician and say, would you like to be part of this trial, so that your patient can potentially get the therapy on this trial.
Great, thank you. That's great to hear about those resources. And speaking of very important new resources, I was intrigued, Whitney, to read about the Latitude assay, which is offered for individuals who may not have had access to the initial fingerprint process that you mentioned earlier. And this is very exciting because certainly there are a number of folks with esophageal gastric cancer under treatment who did not have Signatera performed initially. Could you just tell us a little bit about Latitude and what it might offer?
Sure. Well, two things. We can build a test on tissue that's like years old. If we still have, if it's still archived, we can make the fingerprint on it at any point in time. We just don't have the retrospective blood draw, so it would be whatever the snapshot in time is of their disease at that present moment. But yeah, Latitude is a tissue-free, tissue-agnostic, methylation-based assay. So we look at methylation patterns and in the blood and identify if the cancer is present on a molecular level based on that. Latitude is launching, so that's our tissue-free based molecular residual disease assay. As Ari alluded to, tissue is the gold standard. We 100% agree with that, but there are times where you can't get tissue. And so that's where Latitude would come into play. It is being launched anytime now, commercially in colorectal cancer first, and then kind of early next year, we'll launch it in all the other cancer types. But if there's tissue available, that would be our top priority. And if not, then Latitude is a great tissue-free based test.
Thank you. Thank you, Whitney. Terrific. Well, we'll conclude. We're a little bit over time, but just with a comment from offered by one of our participants who basically indicates that in the course of shared decision-making with their oncologist, they're receiving both the Caris and Signatera tests to guide their treatment. So there certainly are opportunities for both of these very important platforms to be very important to our community. Thank you both again. We'd like to, again, as a reminder, mention that we have a very exciting program coming up a week from this evening, our Ask the Expert support group, which will feature a GI oncologist who can answer some of the clinical questions, which I apologize we really were not able to get to this evening, but which we know are very important. So please join us next week for that session as well. And again, our heartfelt appreciation to Ari and Whitney for their time, and to Aki and Team Hope for their sponsorship of this session this evening.